So we'll hear more about robotic surgery from Dr. Nabeel Nazeer. He is
Thank you.
senior laparoscopic surgeon from Lifeline Hospital, Chennai. And sir is going to talk about past, present, and future of robotic surgery. Over to you, sir.
Hello, am I audible?
Yes, yes, you are.
Yes, so greetings to everyone. I think, since we are not having a physical meeting, I can remove my mask.
Yeah, of course.
So, first of all, greetings to everyone all around the world. Good morning, good afternoon, and good evening. So, before I start my talk, I would just want to address one thing. I would like to share my greetings and salam to Dr. Anwar Khurshid, who was the founding chairman of the school I studied in. So it's a great honor for me, sir, to give a presentation with you in the audience.
Thank you very much, Dr. Nabeel.
Thank you, sir.
Nice to see you.
Nice
Thank
to
you.
see you also.
Are you getting?
Yeah. Is it
Now,
visible?
yeah.
Okay. So I'll be talking about the past, present, and future of robotic surgery. So as everyone knows, robotic surgery is done on a regular basis in high-end premier institutes and in institutes, who can afford the cost of a robotic. So our aim as robotic surgeons and our aim as a medical fraternity is to give the best possible care to all sects of society. The best possible care should not only be given to the high end, the cream of the society, the people who can afford, but to bring down the cost of robotic surgery and give the best to the people of to our country. So as surgeons, we know we cannot go as far as millimeters. The precision is more in robotics. So if I want to move in the robot about 2 millimeters, I can do it. But technically, if I'm doing an open surgery or a laparoscopic surgery, I will not be able to move 2 millimeters in precise. So the surgeon is in control of the whole surgery the whole time, and the surgical system responds to the direction that the surgeon provides. So what is the difference between regular, open, laparoscopic, and robotic surgery? So the console where the surgeon sits ensures that the surgeon has high definition view, 3D magnified images, and they have increased accuracy and vision inside the body. So when I'm operating a colorectal surgery, it's basically, I feel like I'm sitting inside the patient's pelvis and operating, even though it sounds wrong, but that's how it is. Compared to traditional surgery, robotic surgery provides your surgeon with a greater range of motion and movements, and it is very precise. So a lot of people say, sir, you're doing a robotic surgery. Don't you trust your arms? Don't you trust your hands to operate? Is it safe? Yes, it is safe. Robotic surgery is proven to offer consistent, reliable results with decreased post-operative pain and complications, which I will be talking in the further slides. So I'll just go to the past of robotic surgery. I'll not go into the details and the logistics and the history and the numbers. I'm just going to go have an overview of what robotic surgery is in the past and in the present and the future. So in the past, the robotics were used almost 50 years now. But the actual use began in the late 1980s, which is used in prosthetic hip replacement. I think, Dr. Sadish will be excited to know that, they were the first pioneers, orthopedic surgeons were the first pioneers who actually had the guts to start robotics, in the world. The first ever documented robotic surgery was a robotic assisted surgical procedure in 1985 using the Puma 560 robot, which was a delicate neurosurgical biopsy, which is a non-laparoscopic surgery. So if you see the machine, the robot that was used for the femur almost 30-40 years ago, it more looks like a Bachelor of Engineering final year project. It looks so shabby, but as time has come, it has evolved to a great extent. So this was the Puma robot that was used for the neurosurgical case. So where do we stand right now? If you see to the left of the screen, you have a freehand surgery. This is where surgery started. Everyone used to have an open surgery. It used to be a laparotomy, or it used to be any open surgery, irrespective given to the aesthesis of the patient. And then slowly, as time progressed, we are now doing minimal invasive surgery, that is laparoscopic surgery. And then it has moved on to an era where we do robotic assisted surgery. So in the last 5-10 years, there are a lot of institutes who offer robotic assisted laparoscopic or robotic assisted open surgeries. Now our vision as surgeons, as and medical professions, is to do a surgery with full automation, bringing into the aspect of artificial intelligence and nanobots. So what is the present of robotic surgery? Before I go into the present of robotic surgery, I would like to touch upon the important timelines. So in 1985, the first documented robotic surgery was done. That was a brain biopsy using CT guidance, followed which a prostate surgery was done by the robot. And eventually the Da Vinci came and revolutionized robotic surgery. They did the first tubal recanalization in 1997, and in 2005 they did a robotic assisted hysterectomy. So in the present scenario, in which departments is robotic surgery helpful and used on a regular basis? So you will know that cardiac surgery, cardiac bypass surgeries, they're doing a robotic assisted bypass surgeries, and it is a fact that the most number of robotic surgeries done all around the world, in the US, in Asia, is in the GI surgeries, the gastrointestinal surgeries, because you have, as you all know, GI is a Pandora's box. So you can do a pan abdominal surgery using robotics. Gynecology, so the females, the anatomy, they have a very narrow pelvis. So when they have a narrow pelvis, doing laparoscopic surgery or open surgery is a little challenging. So this is where the robotic arms come into play and makes gynecology, a walk-in that is used right now in India and internationally. This is the Da Vinci robot, where you can see to your left, you have a surgeon's control, where the surgeon controls the robot, and then the surgeon's movements are replicated by the patient side robotic cart, and then the vision tower is there so that everyone can see what surgery is going on. And this is the CMR robot that we have in Lifeline Hospital, and you can see the master control and the slave control on the right. This is the newer robot that is brought into the market. This is the Hugo robot by Medtronics, and they are also in their initial phase. So I will not go in detail as what are the benefits and the disadvantages of robotic and laparoscopic surgery. But the one thing that I would like to stress here is robotic surgery is, helps people come back to normal life as soon as possible. So that for any non-GI surgery, the recovery period is around 12 hours to 18 hours. And for a GI surgery, it is 12 to 24 hours. So just to have an idea as to how robotic surgery helps us, to the right you can see a robotic suturing that is being done in virtual reality, where you can see that the endo arms, the wrist, moves like a human wrist. So suturing is made a lot easier in robot compared to a laparoscopic surgery that is on the left. Basically, laparoscopic surgery is giving chopsticks and asking us to eat. So if you see, you have a scary war zone on the left, open surgery, and the same surgery done on the right, where you have a couple of holes and the whole specimen is out by a suprapubic incision. So what is the future of surgery? One quote that I really love by Arthur C. Clarke is, any sufficiently advanced technology is indistinguishable from magic. So what basically robotic surgery and pure robotic does is nothing short of magic. So what is virtual reality in the future? And it's there in few of the states in US and also in our Lifeline Hospital in Chennai. We have virtual reality teaching and learning experience, which takes medicine to a whole new level. We have your VR glasses, which is put on by the tutor as well as the students, and they have a 3D vision of the anatomy of a particular organ, the blood supply, the nerve innervation. So it takes teaching to a completely different level. Something is called, which is called as augmented reality. There's a lot of confusion. People are like, what is the difference between virtual reality and augmented reality? Basically, there are two basic differences. Augmented reality, in augmented reality, patients and the people using AR do not lose touch with reality. And in virtual reality, the information is more, the in-depth information and eyesight is more deeper in virtual reality. So nowadays, for the prosthetics usually done in robotic orthopedic surgeries is 3D printing. and also 3D printing before you go in for a surgery. So if you have a CT guided 3D printing, which technically prints the whole pathology in front of you. So before going for a surgery, you will know what is happening inside and where should I put a nick, where is the artery going. So all this information a 3D printing will give us with a physical form. Google Glasses. My chief, Dr. J.S. Rajkumar, was the first in the world to use Google Glasses in surgery. So basically, when we are operating, for example, a laparoscopic fundoplication or a robotic fundoplication with the Google Glasses on, so I can actually go to the internet and see probably my chief's operation and correlate it with my operation, and I can give the best to the patient. So that also makes life a lot easier. So now we have something called as nanobots, which is still in the initial phase. So to give an example, it basically, for example, you're doing a laparoscopic cholecystectomy or a robotic cholecystectomy. So once I go and I clip the cystic duct and the artery, I have a port which, I let the nanobots go into the abdomen, probably 4 or 5 nanobots in the abdomen. They go posterior in the cystic plate, that is the posterior wall of the gallbladder, between the gallbladder posterior wall and the liver bed, and they slowly shave the liver from the gallbladder. And at the end of the surgery, the nanobots as well as the gallbladder is retrieved. So, and then you have obviously artificial intelligence. So, the future of medicine is artificial intelligence. So, artificial intelligence is gradually changing the practice of surgery with advancements in imaging, navigation, and intervention.
Assisted by the surgeon, or the robot is an assistant and the main surgeon is operating. Can this surgery be done remotely?
Yes,
this is one question.
There are instances where there has been transatlantic surgeries, but as a surgeon, I would not risk doing a transatlantic surgery. I would always like a bedside surgeon to be close by. Since we are the initial stage of robotic surgery, we do need a surgeon in the bedside before operating. As till now, we have done almost thousands of surgeries in robot. There's been no mishaps. The robot has not taken over our OT. But still, transatlantic surgeries has been done in the early 90s. A transatlantic surgery was done from Strasbourg, but the normal notion amongst robotic surgeons is try to avoid transatlantic surgeries. Try to convince your patient to have surgeries in your hospital.
And what is the incidence when you are doing a robotic surgery and suddenly you had to open the patient for laparotomy or had to go out for the conventional surgery?
Yes, if I tell that all my surgeries or all the surgeries that done by my chief were purely robotic surgery, I would be lying. So the initial phase, when we were doing robotic surgeries, we had robotic assisted laparoscopic surgeries. Since we are a premium institute of laparoscopic surgery, so whenever we had difficulty in our initial stage doing robotic surgeries, we had to convert them to laparoscopic. Fortunately, till now, we have not opened any surgery, not done a laparotomy. It's been almost robotic assisted laparoscopic surgeries. But as we grow, the conversion rate has come down to 5%.
Do you do the pancreatic transplant in case of a chronic diabetic who are not responding to anti-diabetic therapy, or rather transplant of the beta cells of the pancreas selectively in the pancreas as a treatment of diabetes mellitus?
No, we are not doing pancreatic transplant in our institute, but what we do, and we are pioneers, are in metabolic surgeries. So we do metabolic surgeries, for example, gastric bypass or MGBs, but we are not ventured into pancreatic or islet cell transplantation.
Because that is the recent thing which is going on
Exactly.
in the robotic surgery.
Yes.
And people are venturing the transplant of the beta cells of the pancreas, particularly in a diabetes which is uncontrolled by the medicine or by the insulin. So I think that is the future of robotic surgery. And I think in India also, at Delhi,
Yes.
I had been, and I found out that probably a lot of things are being done in this particular section,
Yes.
particularly for the patients of the diabetes mellitus.
Yes, sir. Thank you for a valuable input, sir. Thank you so much.
We had a question from Mr. Partha. Sir, can you please repeat your question?
You can hear me now?
Yes, yes, yes.
Yes, sir, you're
Yeah,
audible.
hi, Doctor. Yeah, thank you very much for presenting. Just couple of questions here is,
Sure, sir.
whom do you think are the ideal candidates for the robotic surgery? Are all the cases applicable for robotic, or you have to select some patients who are specifically opted for robotic surgery?
Yes, that's a great question, sir. So initially, when we were in the learning phase of robotic surgery, the patient had to go through the, routine pre-operative fitness by a cardiologist and our anesthetist. So if the patient was fit, because initially we used to do, for example, a laparoscopic cholecystectomy was being done in 15 to 20 minutes, and the first robotic cholecystectomy done by me took around 45 to 1 hour. So if the anesthetist tells me that the surgery has to be done between, within half an hour, it's a high risk case, I will not risk the patient life just to do a robotic surgery. So prior fitness has to be obtained. So as now we are going robotic surgery, including the docking time has come down to 25 to 30 minutes. So if the patient is fit, so the only criteria for patient having robotic surgery is the patient should be fit to undergo anesthesia for about 25 to 30 minutes. And obviously the other factor is your cost factor. The cost has to come down. Robotic surgery is still a little expensive. The insurances nowadays are covering metabolic surgeries and high-end colorectal surgeries, but it has to cover the whole spectrum of surgeries to help people all around.
Okay, so that was about past, present, and future of robotic surgery.